Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra, Season 3. Now, today's topic is very interesting topic: choosing OAD regimens. Today's session is brought to you by your zero calorie electrolyte drink Inaza Zero. Now, before moving forward, I would like to announce the last week quiz winners: Dr. Surjit Kalsi from Noida, Dr. Bharat Praveen Mittakota from Surat, Dr. Anand Purande from Mumbai, Dr. Vimala Kapoor from South Delhi, Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Gangadhar Rath from Bhubaneswar, Dr. Atul Doshi from Mumbai, Dr. Runku Gupta ji from Mumbai, Dr. Abdul Kappar Sheikh from Gurur, Chhattisgarh, Dr. Farhat Thara Nuru Lamin from Kanchipuram, Tamil Nadu, Dr. Pradeep Patru from Chhatarpur, Dr. Ashutosh Das from Tamluk, Dr. Shashi Khare from Bhopal, Dr. Ravi Bhatt from Sirsi, Dr. Hemant Adikane from Pavni, Dr. Sanjeev Puri from Hoshiarpur. So I would like to thank all the doctors to take part in our quiz. Now to enlighten us regarding today's topic, I would like to welcome Dr. Sanjay Kalra, Chairperson Education Working Group, International Society of Endocrinology, and past President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur. Good evening, everyone. As always, we are all logged in 9 p.m. IST to learn more about diabetes and how to manage it. Greetings to Dr. Devraj Dhularia from Surat in Gujarat, Dr. V.K. Goyal, Dr. Gauri Shankar sir from Karnataka, Dr. Ajay Kumar Lalji, and Dr. Manu Sharma from New Delhi. And warm greetings to Dr. Armias Gebre Michel from Ethiopia. So, Armias, let me try my Amharic. Melikami Mishiti. Did I pronounce it right? Melikami Mishiti. That's a beautiful good evening in Amharic, the language of Ethiopia. Today we'll be talking about how to choose an OAD, how to choose an oral drug. And this is actually quite complicated now. Life was so much easier for me when I was a student. We had just two classes of drugs, only two classes of drugs. And now, where are my slides? Here, I find them. Okay. Uh, we had only two classes of drugs, maybe three or four types of drugs, and it was quite easy to choose between them. But now things are complicated. So let's try to make it simple. And how do we make choosing an oral glucose lowering drug simple? We go to one of our favorite games, supposedly a very simple game. And this is Kabaddi, the national game of Bangladesh, a favorite game of Iran, and the state game, the official state game of 12 states in India at least. And right in blue in the center, you see my favorite team, that is Haryana Steelers, and fighting against you, Mumbai. And now, Pro Kabaddi League is going on. Haryana Steelers is doing very well. They've qualified for the playoffs. And I'm actually inspired by their team, their players, and their coach. So let's try to take inspiration from Kabaddi and see how we choose an oral drug. What are the rules of the raid? When you go into play Kabaddi, there are seven players on this side, seven on the other side. In most modern Kabaddi games, four people take the four players come to the court initially. The other three are kept in reserve. So what do? You have to raid the opposing side, isn't it? And you have to touch as many opponents as possible while coming back to your side of the court, continuously saying the word kabaddi, 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 kabaddi. And this has to go on for a maximum of 30 seconds. So what do? Do you just rush into the opposite court, the opposing court, and try to do whatever you want to do? Or do you, first of all, look around, see the lay of the land, see how the opponents are placed, where they are standing? Of course, we do that. So that's what we'll do when we look at OAD choice. Look at the patient, assess the patient, assess not only the glucophenotype of the patient, that is the glucose levels, but also the complaints and concerns. C for complaints, C for concerns, C for complications, C for comorbid conditions, and most important of all, C for clinical features. So let's repeat these five C's again. C for complaints. What complaint is the patient, uh, you know, verbalizing? What are his or her concerns? Is he or she worried about efficacy, good glucose control? Is he or she worried about safety, tolerability? Complaints, concerns, then clinical features. What is it that the patient has come with? Are there any features suggestive of diabetes directly due to hyperglycemia or maybe hypoglycemia? And this brings me to a quiz question. What are the signs of hypoglycemia? Note the question. The Google is not the symptoms. What are the signs of hypoglycemia? Hypo. Fourth and fifth C are the complications and comorbid conditions, because these will also help us decide which OAD to use, which not to use. So coming back to Kabaddi, you've seen the opposing court. Then you step back, take a deep breath, because remember, as a raider, you have to chant Kabaddi, 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 Kabaddi continuously for up to 30 seconds. So you need to take that deep breath. And then after that, you assess your targets. Now, there are four opponents. If you begin the game, there are four opponents on the opposing side. Similarly, we have four targets for us. Each of them, at a particular point of time in a particular patient's journey with diabetes, there will be different weightages for this. At one point of time, it may be glucose control, which is the most important. For the very next patient, it may be weight control, which is really important, which is paramount. And even within the same patient, there is intra individual variability. Today, the patient wants me to focus on glucose, so I do that. That is what is required. But once that is taken care of, then we want to focus on cardiovascular health, renal health, so long term outcomes. Let's make this simpler. In some patients, it may be an acute or short term concern, so we focus on that. In others, it may be a long term concern, so we focus on that. What are the acute short term issues? These will be more important when the patient is sick, when the patient is symptomatic, is severely hyperglycemic, or is awaiting surgery. Sick, severely hyperglycemic, symptomatic patients may be awaiting surgery. Here, the focus is more short term. On the other hand, if the patient is stable, as for stable, once you have stabilized the patient, then the focus, the choice of an OAD is determined more by long term outcomes, which are cardiovascular, renovascular outcomes. So let's go back to Kabaddi now. First, we looked around, saw the lay of the land, looked at the patient's complaints, concerns, clinical features, comorbidities, and complications. We stepped back, took a deep breath, looked at the opponents facing us. Are they the acute ones, the sudden ones, like uh, we need glucose control and weight management? Or are they the long term ones because the patient is stable, vascular control? Then we explore our armamentarium. The captain of the Kabaddi team, the coach, looks at the armamentarium. What kind of players do I have? How many players should I send in? Of course, only one raider can raid at one time in Kabaddi. But in diabetes, we have kind of freedom. We can choose to initiate one oral drug, or two oral drugs, or three oral drugs together. This is called hit early, hit hard. Hit early, hit hard. If the HbA1c at baseline is more than 7.5%, begin with two oral drugs. If the A1c is more than 8.5, begin with three oral drugs. If it is below 7.5, which would be very rare in India, Pakistan, Afghanistan, or in Ethiopia, then you can initiate monotherapy. So now we have a fair idea of the rules of the raid, and suddenly we are beginning to enjoy Kabaddi, isn't it? And let's hope that the best team wins the Pro Kabaddi League. And of course, you know where my cheers are going to lie. Let's come to another aspect now of Kabaddi as well as OAD choice. We have a we have a responsibility to the patient to ensure efficacy along with safety and tolerability. So you have to be efficacious and efficient. What does that mean? We should be able to control glucose very well, efficaciously and efficiently as fast as possible. At the same time, we have an equal responsibility to ensure safety and tolerability. Whatever drug we use and whatever glucose lowering approach we use, it should be safe and it should be well tolerated. Both go hand in hand. Like in Kabaddi, raiding and defending go hand in hand. You need good raiders and you need good defenders in your team if you want to win the cup, if you want to win the match. At times, however, you can sort of play with the relative importance. A person who is young, who has more years to go in diabetes, who has less chronic complications, a person who is young with shorter duration of diabetes, who has longer to go in life, who has less chronic complications, a person who needs immediate glucose control to resolve any associated comorbidity, which might be infection, inflammation, invasion, irritation, that is psychosocial, or iatrogenic. A procedure is being awaited, maybe a surgery. Here, efficacy is paramount. On the other hand, a person who is relatively elder, who has had more years of diabetes, has lived with diabetes for more than 10 years, who may have chronic complications, such as hypoglycemia awareness, which is part of autonomic neuropathy, which is part of microvascular complications, which is linked with macrovascular complications. So, a person who has lived longer with diabetes, who has more complications, who is at more risk of hypoglycemia, here safety and tolerability will be paramount. So now again we have a fair idea how aggressive should we be in the kabaddi court. It depends. If you're winning the match and you know you've already qualified for the playoffs, then safety and tolerability. You don't want to harm or injure any of your players. On the other hand, if you are staring at being knocked out of the playoffs, or it's just 5 minutes left for the second half of the game, each half is 20 minutes long, and you're afraid of losing the match, then you go all out for efficacy. Then you don't bother too much about safety tolerability. That will come later. So now we know when to raid, we know when to defend. But if you've seen the kabaddi court, the defenders tend to hold their hands together, all four of them together. That gives them more stability. It gives them greater chances of being able to catch the raider when he enters their court. And this is what we do with combination therapy in diabetes. That's why we said you might wish to initiate 2 or 3 drugs right at the very beginning. Initiate 2 drugs if the A1C is more than 7.5. Initiate 3 if it is more than 8.5. In my practice, actually, most of the patients do come in with HbA1c more than 8.5. So we are used to starting triple oral therapy. Holding hands is also like FDCs, fixed dose combinations. So when you use fixed dose combinations, you're able to reduce the pill burden. You're able to strengthen um, your therapy, and you're also able to give the patient a feeling of being taken care of. And the patient gets a feeling, yes, I'm taking 2 drugs, but they will be effective. They will be efficient. Using fixed dose combinations or combinations also allows you to use lesser doses of each drug, especially of sulfonylureas. So when you're using lower dose of sulfonylurea, you are actually working towards safety and tolerability. When you're using a lower dose of metformin or of pioglitazone, again you are working towards more tolerability. So this holding hands in kabaddi, the way the defenders do it, this tells us how to defend our turf against hyperglycemia, against the complications of diabetes. So far we have looked at two aspects of kabaddi, and we have tried to, correlate them with diabetes care. Let's remind ourselves of these two aspects, and then we move on to the third one. And then we talk about the drugs to use. In kabaddi, you don't have so much time actually. We are still warming up for our topic. In kabaddi, it's just 20 minutes, and the raider has just 30 seconds to go in and come out. So we need to be a bit fast as well. But let's go to our first topic. The first concept was, first, look around, see the lay of the land. Complications, comorbid conditions, clinical features, concerns, and complaints in reverse order. Step back, take a deep breath, analyze the targets in front of you. Are they acute or short term oriented, like glucose control, weight optimization? Or are they long term, cardiovascular health, renal health? And we choose four because usually there will be four opponents when you go to rate the kabaddi court. If your patient is stable, then we focus on cardiovascular, renovascular health. If, however, your patient is sick, symptomatic, severely hyperglycemic, and awaiting surgery, sick, symptomatic, severely hyperglycemic, awaiting surgery, full of complaints and concerns, then focus on the acute aspects first, glucose and weight control, and also correcting the comorbid condition or the complaint, whatever the patient has come with. Now that you've assessed your target, then you explore your armamentarium, whatever drugs you have available, and choose the number of drugs that you wish to start. That would be the first choice. Do I want to start with monotherapy, dual, or triple oral therapy? After having revised this concept, we move to the second one again: efficacy and efficiency versus safety and tolerability. It doesn't always have to be versus, it can be together. Just like in Kabaddi, you need good raiders and defenders, but we need to know what to focus on in a particular OPD consultation. You can always change next week. And remember to hold hands the way Kabaddi players hold hands, that is, combinations and fixed dose combinations for us. Now we come to our third concept. And after these three concepts, we'll be able to go to micro planning and choose our drugs. These three words in front of you are initiation, intensification, and interchange. Initiation means the patient has come to you for the first time. The patient is treatment naive. Patient has not taken any drugs, so we need to initiate. So I have to decide whether to give one or two or three drugs. Intensification is patient has already been taking treatment from another doctor or from me, and there is an efficacy issue. Glucose levels are not at control. Then I have to intensify, which means I have to add. From single, I may wish to go to dual or triple oral therapy. From dual, I should go to triple oral therapy. Very rarely we write four drugs. Ideally, that should be discouraged, but in practice, we have to do it. Ideally, after triple oral therapy, you should intensify to insulin. Many times you will see our prescriptions where we are giving four drugs, four different types of drugs. Um, that is a temporary kind of a stopgap arrangement, because in the background, a lot of communication, a lot of counseling is going on regarding insulin therapy. That communication and counseling is very difficult to sort of encapsulate or write on an OPD prescription. But simple rules that you can follow are advised insulin strongly, recommended insulin, whatever words you wish to use. And even if the patient comes back to you a year or 2 years later, you, from your words, whatever you've written in the side notes, you know how strongly you had advised insulin. What some things that you can do is suggest insulin means it was a soft suggestion to the patient on that particular day at that particular time. Advised means you are firm, and strongly advised, not willing, means you are quite firm. Patient still didn't agree, so you gave four oral drugs. But coming back to our III, initiation is when you are treating a treatment naive patient. Intensification is when there is an efficacy issue and you have to add a drug. The mistake that many of us make is actually there is an efficacy issue and we end up interchanging. Interchange means this is done when there is a safety or tolerability issue. So maybe I have been giving glimepiride to my patient. Patient gets frequent hypoglycemia. So I will interchange. I was giving pioglitazone. Patient got edema. I will interchange. Patient had been taking SGLT2 inhibitors, got recurrent refractory or resistant genital tract infection. We will interchange. So interchange is when there is a safety or tolerability issue. If there is an efficacy issue and you end up interchanging, you will not be able to achieve good glucose control. The point we wish to make here is you have to intensify. If you are not achieving targets, you have to add a new drug. Now that we have learned lots and lots of Kabaddi, let's look at our players now. In Kabaddi, they have 7 players per team. In the Diffronzo octet, we have 8 kind of players. 8 players in the pathophysiology of diabetes. Let's look at them one by one. From the pancreas, you have the beta cell, that is impaired insulin secretion. You also have insulin resistance, which plays out at the adipose tissue, the skeletal muscle, and the liver. Also at the alpha cell, which produces glucagon. So we can take all these together. Not only is there insulin resistance in people with diabetes, there is also incretin insufficiency. So the gut is another player in diabetes. And increasingly so, we are speaking about the kidney, which resorbs glucose. This is maladaptive reabsorption of glucose in people with diabetes. And the brain. There is insulin resistance at the level of the brain as well. Drugs can be used to reduce insulin resistance at the brain, but lifestyle modification also helps. You can actually counsel your patients that if there is insulin resistance in the hippocampus, insulin signaling is impaired at the level of the neuronal synapses, and that leads to reduced cognitive function and to reduced memory. So, if your patient with diabetes complains of fog, brain fog, inability to think, reduced cognitive function, reduced happiness, it's not necessary that the patient has distress or depression or needs to get an evaluation for schizophrenia. It just might be hyperglycemia per se. So you correct the hyperglycemia, and those synapses, those neuronal synapses, the insulin signaling will come back to normal. Now, suddenly, all of us are feeling so far things were so happy in this lecture. We were happy with Kabaddi. We were happy up till 7 players. Now we got eight. Okay, and now this slide is even worse. How do we understand this? This is from ADA 2024, and they tell us how to choose glucose lowering medication. And actually, what we want to do today is to make this slide simple. So let's move ahead. This is a classification that we had written a few years ago. We classified all the insulin drugs into four classes. But this is an even older classification that we've written, and this remains my favorite. This is what I use in the OPD. So let's focus on this slide today. Just like you wish to manage maybe a fluctuant abscess, we have a choice of bacteriostatic antibiotics, bactericidal antibiotics, and incision and drainage. Similarly, in diabetes, imagine that diabetes is a fluctuant abscess of glucose, of hyperglycemia. We have choices. We have glucostatic drugs like insulin sensitizers. We have glucosidal drugs like the sulfonylureas. And we have our medical incision and drainage. You can do the incision at the level of the GIT using acarbose and voglibose, or you can do it at the level of the kidney using SGLT2 inhibitors. Now, do remember that this classification is meant to make things simple for us, not complicated. So, at the level of simplicity, the insulin sensitizers or the glucosidal drugs are metformin and pioglitazone. You will need to use metformin for almost all your patients, almost all, unless there is an absolute contraindication, maybe EGFR less than 30, or the drug is just not tolerated at all. Patient is not even able to take maybe 250 milligram TDS. Otherwise, 90 to 95% of all your patients should be on some form of metformin or the other. This is assuming that they are type 2 diabetes without chronic kidney disease stage 5 or maybe 4. So we take one sensitizer, which is usually metformin. We can take one secretagogue. When you are giving combination therapy for antibiotics, then remember what you do. You take one antibiotic which focuses on gram positive and the other one which has gram negative coverage, maybe anaerobic coverage as well. Similarly, it would make more sense to give one sensitizer and one secretagogue. Suddenly, many of you will say, yeah, but in traditional pharmacology, we were taught you cannot give a bacteriostatic and a bactericidal antibiotic together. That was true, but in modern pharmacology, actually, that is allowed. Linezolid is a bacteriostatic antibiotic, which is used in diabetic foot, along with other bactericidal antibiotics. That's one answer. The second is that this concept is basically for our simplicity, for our understanding. So, one sensitizer, that would be the first choice. But like we said, most of our patients will come in with an A1C more than 7.5 or 8.5. So, we have to add a drug. We can choose a secretagogue. If our focus is on efficacy, efficiency, immediate control, swift control, then a sulfonylurea would be better. Glimepiride 1 milligram BD, glyclazide 60 milligram BD. This is what we would start with. You can always go up or down. These are directly acting secretagogues. On the other hand, if our main aim is safety and tolerability, or maybe we've not been able to get all the renal tests done, or the patient says, I'm coming from far off, from up country, I will not be able to visit you for the next 3 months, then it would be a good idea to choose an indirectly acting secretagogue. And here the drug of choice would be a DPP4 inhibitor, vildagliptin, sitagliptin, linagliptin. Linagliptin, only one drug, only one dose, 5 milligram OD, irrespective of renal or hepatic status. For sitagliptin, 25, 50, and 100 milligram. If the EGFR is above 30, above 50. So above 50, 100 milligram, above 30, above 50, 100 milligram, above, below 50, 50 milligram, and below 30, you can give 25 milligram. So easy to remember. Vildagliptin, it's easy, just two choices, 50 milligram OD or 50 milligram BD. 100 milligram OD preparations are also available. The EGFR cutoff you can take as roughly 45 for deciding whether to give 50 per day or 100 per day. So coming back, we have to give a sensitizer, which will usually be metformin. You should give a secretagogue in most patients. If you want swift control, sulfonylurea. If you want slow control but safe control, then DPP-4 inhibitors. It will also depend, the choice will also depend upon how high the glucose level is. If the A1C is 8 or 9 or 10, then DPP-4 inhibitors do act. It's not that they don't act, but you will need uh, a stronger drug, which would be sulfonylurea. Now, if the HbA1c is really high and you need a third drug, or you are also focused on cardiovascular safety, long-term outcomes, then it would be a good idea to choose SGLT2 inhibitors along with these two. So this is how we choose. So let's go back and revise. Kabaddi. Look around, see the lay of the land, step back and take a deep breath. Look at the previous pharmacological history. See the previous drug therapy. If the patient is drug naive, of course, no issue. But if the patient has had an efficacy issue with previously prescribed drugs, then you have to intensify. Maybe my patient is on pioglitazone plus metformin. Glucose is not at control. Then I need to add a third drug. I need to intensify. That will usually be a sulfonylurea in this case. If my patient was already on metformin and sulfonylurea, adequate doses, glucose is not controlled, that is an efficacy issue, then I need to add a third drug. I have already given a sensitizer. Patient is already taking a secretagogue. What do we add next? We add the calorie restriction mimetic or that incision and drainage. So SGLT2 inhibitor will be added. Another scenario. Step back, take a deep breath, look at the previous pharmacological history. There is a safety or tolerability issue. Patient says, Sir, I'm on this treatment. My glucose is under control, but I've been gaining weight. I've gained 5 kg in the last 3 months. That means pioglitazone is the culprit. Stop that, interchange, give an SGLT2 inhibitor. Patient says, Sir, I'm fine. The glucose is okay, but I'm not happy. I have chronic itching in my genital area, pruritus vulvae or melanoposthitis. That means SGLT2 inhibitor is the culprit. So stop that, maybe add acarbose. So look at the previous history, assess your targets, and choose your drugs wisely. Depending upon how high the glucose levels are, you may wish to choose one or two or three drugs. If you choose one, it should be a sensitizer, usually metformin, sometimes pioglitazone. If you choose two, if it is an acute issue where you are focusing more on glucose control, then the drug of choice would be sulfonylurea. If it is an acute issue and you are focusing more on weight control, then maybe SGLT2 inhibitor or oral GLP-1 RA. Semaglutide 3 milligram you can start with. You can always go up to 7 and 14. If, however, there is no pressing acute concern or complication, a concern or complaint, and then you wish to add something, then it would be a good idea to add an SGLT2 inhibitor. So now we have a fair idea of how to move ahead. We need to know more about all the drugs as well. Now, especially about the side effects. So let's look at some important facts regarding all the drugs. Metformin is contraindicated if the EGFR is less than 30, and GI side effects may be common. So if a patient complains of GI intolerance with metformin, first of all, rule out gastroparesis. Rule about protozoal infections, helminthic infections, which are very common. That would be the commonest in our part of the country. Rule out lactose intolerance. Ask your patient, especially if patient is from Northwest India, how much milk do you drink per day? And patient says, oh, I drink 2 liters of milk every day. I've been drinking it for the past 60 years. But then you have to tell them that, 60 years ago, your GIT was different. The lactase enzyme was different. Now, maybe the lactase enzyme has become a bit older. So let's try to reduce the milk. So, diabetic gastroparesis, protozoal and helminthic infections, and lactose intolerance. These are commonest in my practice. If all these are ruled out, then you might wish to change the formulation of metformin. Try sustained release, try immediate release, give it night, give in the morning, and see what is the best possible you can do for your patient. SGLT2 inhibitors, the main complaint that we see with them is genital fungal infections. If your patient is frail, catabolic, do not use SGLT2 inhibitors, please. Your patient is already catabolic, losing weight, unhappy, frail. Wait for some time. Correct the acute issues first, then later on you can give SGLT2 inhibitor. Oral GLP-1 RA are available. You have the only issue here is cost. It's about 300 rupees a day. You can give the tablet 30 minutes before breakfast with maximum 100 ml of water, and there will be mild transient GI side effects which resolve within a few days. Weight loss is the advantage of using oral GLP-1 RA. DPP-4 inhibitors we've already mentioned, and the best point with them is safety. You don't need to do any tests. However, do be aware of that if there is unexplained joint pain or if there is unexplained dermatologic issue like bullous pemphigoid, then DPP-4 inhibitor may be the culprit. So any unexplained rheumatological, unexplained dermatological issue, think whether the DPP-4 inhibitor is at fault. Pioglitazone, uh, weight gain and congestive heart failure, fluid retention, these are the only issues, but they actually help in fatty liver. So pioglitazone would be a preferred drug in two situations: people with uh, evidence of MAFLD, and also people with past history or those who are at high risk of stroke. Pioglitazone helps in reducing the risk of stroke, and it also reduces hepatic fibrosis. Sulfonylureas in India remain our mainstay along with metformin. Try to use lower doses as low as possible, and tell your patient that the moment glucose levels come down, we will try to reduce the dose of sulfonylurea. So now, by now, I hope that you have a fair idea of how to use all the drugs that are available. The first step would be to classify the drugs into three groups. So coming back to this slide, insulin sensitizers, which are glucostatic, insulin secretagogues, which are glucosidal. And let me repeat again, this is just for our understanding purpose. And SGLT2 inhibitors or alpha glucose inhibitors, which are our incision and drainage, they are nutrient load reducers. So we have the armamentarium with us. See whether you are at the initiation, intensification, or interchange platform. Act accordingly. See what is the main issue today or at this particular time in the OPD for this particular patient. Is it efficacy and efficiency, or is it safety and tolerability, or maybe both of the above? See whether your patient's clinical features, complaints, and concerns require you to raid the diabetes arena or to defend your turf. Irrespective of what you do, do not forget to hold hands. Use combinations, use FDCs, hold hands with fellow colleagues as well. Do not hesitate to take the help of a retina specialist, a psychologist, an obstetrician as and when required. And again, back to Haryana Steelers, look around, see the lay of the land. Step back, look at the previous pharmacological history. Assess the targets in front of you. Are they acute or short term or maybe both? See what drugs are available, which drugs have not proven their benefit because of efficacy safety issues in the past. Change your drugs and then decide whether you wish to give one, two, or three drugs. Now, things have become so simple for us, isn't it, suddenly? So let's look at two quiz questions and then we take questions from the audience. Our first question for today: what is the primary goal of managing diabetes? And let me remind all of you, this is a googly question. What is the primary goal of managing diabetes? Is it to alleviate symptoms, or is it to minimize fluctuations in glucose levels? Maybe to prevent long-term complications, or perhaps all of the above. So let's repeat the question. What is the primary goal of managing diabetes? A, to alleviate symptoms. B, to minimize glycemic fluctuations. C, to prevent long-term complications. And D, all of the above. And if this was Not enough of a googly. You haven't seen question two yet. So this is an even longer and tougher googly here. Now I wonder what the word for googly is in kabaddi. But actually, there is a concept like that in kabaddi. That is when you get everybody out. So a super raider uh, goes into the court and is able to get out everyone, three or more than three people out in the opposing team. That's a lona. And then what happens is you get 2 points extra, and then everybody gets rejuvenated. All the people who got out, so they come back. So that's how it is in diabetes actually. If you've been able to control glucose in your patient today, that doesn't mean you've won the war. You've just won one battle. You have to continue the war. It's a lifelong fight against diabetes. So, question two: which strategy is effective for managing diabetes? Which of the following? Is it A, begin with one or two or three oral drugs based upon HbA1c level along with lifestyle modification? Or perhaps B, start one drug and add a second glucose lowering drug only if there is no relief within few months? Perhaps C, avoid oral drugs in diabetes and use only vitamins to manage glucose? Or D, all of the above? So let's repeat our choices again. Which strategy is most effective? Is it A, starting with one or two or three oral drugs based upon the baseline HbA1c along with lifestyle modification? B, starting with one drug, adding a second one only if there is no control in few months? C, avoiding all oral drugs and using only vitamins to manage glucose? And D, all of the above. With this, let's take our questions for today, and I thank everyone for having been with us. Here we go to stop screen and okay, so lots and lots of questions. So we'll take them one by one. Once again, thanks to everyone for being with us. We forgot to speak about special situations, and Dr. Devraj says chronic kidney disease, which are contraindicated. So easier way would be to say which are indicated. Chronic kidney disease, even if the EGFR is 1, you can use linagliptin. So that would be the safest, 5 milligram OD. Amongst the sulfonylureas, the safest would be glyclazide XR. You can give 30 or 60 milligram OD. Glyclazide sustained release, 60 or 30 milligram OD, or glipizide, 5 milligram OD. These are the safest. If, however, your patient is sick, frail, it would be a good idea to convince them to take insulin. Good evening to Dr. M. A. Lambe and Dr. Vinay Desai as well. Dr. Vinay shares a challenging case, 40-year-old lady, fasting 120, postprandial 230 after 1 month of metformin twice a day. Now her fasting is 120, PP is 137. So her fasting is not coming down. This is quite common in practice. How we explain to the patient is that your daytime glucose is linked with your daytime activity. In Hindi, I would tell this patient, very well done, madam. आपकी दिनचर्या बहुत सात्विक है. Your daily routine is very equipoised, balanced. इसीलिए आपकी दिन की शुगर जो है वो भी सात्विक हो गई है. That is why your daytime glucose is very well controlled. Thank you, madam, for taking care of yourself. However, the fasting glucose is mediated by hepatic insulin resistance. So your fasting glucose is actually coming from the liver. Now, this is an adaptive mechanism because what will happen if you get hypoglycemia at night. So your liver is working overtime to prevent you from doing that. But here, what we can do, either we can add 500 milligram more of metformin at night. That answer actually will depend upon the HbA1c, or you can add a DPP4 inhibitor at night. We can also add a sulfonylurea. Like we can give an FDC of metformin plus glimepiride zero point 0.5 or 1 milligram. So these three choices are there. Personally, I would not go for the increased metformin unless the HbA1c is 6.8, 6.4. I would prefer here, glucose levels are not all that high. I would prefer to add maybe vildagliptin 50 milligram with metformin 500 milligram after dinner and then see what happens. HbA1c will help us decide actually which of these three options to take. If the vildagliptin doesn't do the trick or linagliptin 2.5 plus metformin doesn't do the trick, then I'll go one step up. And instead of using this indirectly acting secretagogue, then I'll give a directly acting secretagogue. Then it will be glimepiride or glyclazide plus the metformin at night. Daytime treatment will remain the same. Dr. Gauri Shankar asks about patient on thyroxine 100 microgram once a day. If the TSH is normal, we should continue. Tell the patient you are driving your car. If you are driving well, then you will not change the gear. So let us continue. If TSH is raised, then we increase to 1 to 112 or 125 microgram per day and check again after 6 weeks. Sometimes this change in TSH suddenly it may be because of non-pharmacological factors. Maybe patient has decided to take turmeric water or fenugreek water early in the morning along with thyroxine tablet. So ask the patient, are you taking any folk therapy, any complementary therapy in the morning, 1 or 2 hours before or after the thyroxine tablet? If yes, please stop. So any kind of basil water, turmeric water, fenugreek water, honey water, all these things reduce the absorption of thyroxine. Very rarely, patient may have started soya bean milk in the morning. That reduces the absorption of thyroxine markedly. So stop that. And another common cause is biotin. Patient may have started a new multivitamin without telling you, which contains biotin. Biotin interferes with the TSH assay. So it's not that TSH will actually go high, the assay becomes sort of erratic. So you can counsel the patient to stop that biotin tablet a week before getting TSH done. Biotin high dose will be most commonly seen in the dermatology segment. So patient might have gone and shown a dermatologist for hair fall, hair loss. So these are some common things to look at as well. Good evening to Dr. Vinayak Sharma. Dr. Vinay Desai, okay, shares weight is 64 kg with that lady and she has lost 4 kg after 1 month with metformin. Now that weight loss can actually be because of lifestyle modification. It can also be because of poor glucose control. So the word here is weight optimization. If patient wants to gain weight, you can add pioglitazone at night. So that metformin will change to metformin 500 plus pio 15. If patient wants to keep the weight same, then add the vildagliptin or linagliptin. If patient says that she wants to lose more weight, then you can think of adding alpha glucosidase inhibitor. Dr. Suresh Shukla asks, in fatty liver, Lina or Vilda, so linagliptin will be safer in liver disease. Certainly, linagliptin is safest in liver disease. Vildagliptin would come at the bottom of the hierarchy. Dr. Devraj, sorry if the voice is not audible. I hope it is better now. On my system, the audio is at maximum. Can we ask backstage? I think Faraz is with us today. Faraz, any issues with audio, just let me know. Dr. Gauri Shankar talks about a 29-year-old lady with fever, vomiting, and rigors, on and off fever. So we have to investigate. Depends how long she has had. If the fever is lasting more than 4 or 5 days, please investigate for the fever. If it is diabetes, do get a urine ketone done. Don't miss out ketosis. Thanks, Faraz, for your reassurance. And then a question from Dr. Armias. This is from Addis Ababa. The lowest EGFR, where I use SGLT2 inhibitors, about 25 to 30. So we look at the EGFR, Armias, and we also look at the frailty of the patient. Now, this difference I see between Western guidelines and Indian practice or Ethiopian practice. Many of our CKD patients are quite frail. They are not all that healthy. I think our Western colleagues do not see unhealthy CKD patients. So that is why they are a bit more aggressive, more gung-ho about using SGLT2 inhibitors. So apart from EGFR, I would suggest that we look at frailty. If your patient is frail, catabolic, having frequent infections, making it to the hospital every week, every 2 weeks with some complaint or the other, then avoid SGLT2 inhibitors until your patient has become stable. But to answer your question, it would be around 25 EGFR. Fisher foot management, Dr. Gauri Shankar. So, foot actually last week, if you can go through it, it was nearly 80-minute session with Dr. Suneet Verma, and most of your questions should be answered in last week's recording, sir. And I would agree with you. Mostly triple drug combinations are needed for good glucose control. This is true in most parts of India, and I assume other countries as well, developing countries. If you're in a developed part of the country, patients are coming to you early with HbA1c less than 7.5, then the guidelines will work. But if you're in a relatively less developed part of the country, in rural, semi-rural, semi-urban settings, patients come in late to us and we have to start triple therapy. Osteoporosis, yes, we must start teriparatide or zoledronic acid. This will help because you have documented osteoporosis. Teriparatide is anabolic, one injection every day, 20 micrograms subcutaneous. The cost has come down markedly now. Zoledronic acid is it is not anabolic, it is anti-resorptive, one injection IV infusion per year. So depending upon patient's choice. But if you want immediate control, you want anabolic effect, you want pain relief, the patient to feel happy, then teriparatide would be a better drug. You can choose to give teriparatide for 18 to 24 months and then shift to zoledronic acid for 8 to 10 years. We thank Professor Madhur Verma from Brinda for his kind words. Your eyes and ears are kind to us, sir. Thank you. And Dr. Gauri Shankar raises a point which I also feel. Moxiclav and azithromycin are not working for LRTI because the resistance level has gone up so markedly. And yes, cefuroxime, cefpodoxime, these are good drugs to choose. Yes, sir, you are right. GDM, Dr. Mitagola Bharat Parveen raises an insightful question. So, our opinion regarding acarbose glibenclamide to be avoided at all costs. Glibenclamide will cause hypoglycemia. Even if it doesn't cause maternal hypo, it can cause fetal hypo, and then we get in trouble. Metformin is approved for use in India in GDM. In the West, it is approved for use in first trimester if the patient had already been taking the drug for maybe polycystic ovary syndrome or type 2 diabetes, or perhaps for obesity. So, if your patient has been on metformin prior to pregnancy, you can continue in first trimester. In GDM, the definition of GDM is that it will be diagnosed usually in second trimester or maybe in third. So, in such cases, according to Government of India rules, and in my practice also, we can use metformin. But the red flag, Dr. Bharat Parveen, would be a patient with fetal or maternal distress. GDM with fetal distress, GDM with maternal distress. Stick to insulin. GDM with IUGR, GDM with hydramnios. Stick to insulin. Another point of view is to see the duration. If the patient has come in with high glucose levels at 12 or 14 or 18 weeks, you will need insulin. Uh, I mean, you can't manage the patient for 4 or 5 months. This is assuming that lifestyle modification, MNT, has failed. So you have to start insulin, you might as well start now. On the other hand, if GDM was diagnosed at 35, 36 weeks and glucose levels are not all that high, there is no fetal or maternal distress. It's just 1 or 2 weeks. There's no harm in giving a trial for 3 to 4 days. But whatever trial you give in GDM, don't make it last more than a week or so. Be aggressive, be dynamic, change as and when required. Think of the fetus as well. But remember fetal and maternal distress, and do reach out if you are confused. Do reach out to the obstetrician. Spend a few minutes speaking with her, see what her concern levels are, and then choose accordingly. And this is Dr. Suneet Kumar from Panchkula, where the Pro Kabaddi League is being played these days. And actually, that is the home ground of Haryana Steelers. And Dr. Suneet says he's a good Kabaddi player. Thank you, sir, for your expertise both in the diabetes arena and in the Kabaddi play field. Slides, Dr. VK Goel, sorry, I saw this now. Uh, we will check with backend how we can improve the slide projection next time. And linezolid, clindamycin can be given in foot. Yes, both have good penetration into soft tissue. And linezolid, I think, let's ask everyone in the house, it is more for aerobic infection. Metronidazole is for anaerobic infection. That is why you can give the combination. That, and linezolid does anaerobic coverage as well. So, but let's ask people in the house what you use. Metronidazole is the standard for anaerobic coverage. Dr. Gauri Shankar shares a case, challenging case, CT scan done to show cervicitis and enteral gastritis and fecal loaded intestine. So there might be some kind of subacute intestinal obstruction going on. I think a surgical intervention is required here, at least a surgical consult. And do check urine ketones, check for potassium. This 38-year-old lady with uncontrolled diabetes, she may have diabetic ketosis. then insulin is required, and she may have hypokalemia. If we give a lot of insulin without correcting the hypokalemia, things will become worse. So first a sodium potassium, optimize the potassium, give IV fluids, and then give insulin. Since the patient is sick, now see, she is sick, severely hyperglycemic, she may or may not need surgery, she is symptomatic. Here insulin is indicated. HYQ certainly is safe for both rheumatoid arthritis and diabetes. Thank you, Dr. Suresh Shukla, for sharing this. And yes, Dr. Shashi says we can give GLP-1 RA with secretagogue like glimepiride. Yes, we can. Keep the dose of glimepiride on the lower side, 1 milligram BD, maximum 2 milligram BD. And you can add the GLP-1 RA. We assume that metformin will also be given. Dr. Manu asked a difficult question. So, oral sema certainly is a good drug to use. It will help improve glucose. It will also help reduce weight. So, when to add, you give the option to the patient. And if the patient is concerned about weight loss, the patient wants weight loss and also long term cardiovascular benefit, renal benefit, then we can advise about oral semaglutide. Also, if let us say you have given triple oral therapy and the drugs are not acting, out of those triple oral drugs, three oral drugs, one is DPP4 inhibitor, it's not acting. You can stop the DPP4 inhibitor and start semaglutide. Of course, like Dr. Manu says, cost is the major issue. So, another three I's here, that is inform, incubate, initiate. So, inform the patient about the option of oral semaglutide. Let the idea incubate in the patient's mind, and then you initiate. For some people, actually, weight optimization is a major driver for glucose control, for metabolic control, and they're very happy taking the drug. Cough and cold and fever for 3 days. Again, Dr. Gauri Shankar, Dr. Suneet Verma had spoken about this, about diabetic fever, I think about 1.5 or so months ago. And that was also a long session. So I think all the answers would be there. Dr. Mukesh shares a cardiology patient. If a post PTCA patient is on statin and having lower LDL of L30, should we adjust statin or stop? So actually, data shows that if LDL goes below 30, the outcomes are better. So you should continue. And supposing the cardiologist has started at Orva 80 or Orva 40, please do not stop. Counsel the patient, you keep on taking the drug. These LDL levels, triglyceride levels are excellent. Continue taking the drug until you consult your cardiologist. So please do not stop at all and do not reduce also as long as the patient is tolerating the dose well. The outcomes will be longer. Thank you, Dr. V.K. Goel, sir, for your kind words. And thanks to everybody who has answered, Doc AR, Dr. Lambe, Dr. Rajesh Guvlani, and Dr. Dalaria. Oh, and we have an answer from Dr. Dollar as well. I wonder where Dr. Dollar practices. It's nice seeing your logo. And also thanks to Dr. Gurcharan Singh Batra Sahab for being with us and for answering the questions. डॉलर साहब पूछते हैं व्हाट इज द बेस्ट टाइम फॉर मेटफॉर्मिन ग्लिमेप्राइड बिफोर और आफ्टर अ मील सो आई यूजुअली आई गिव इट 5 to 10 minutes before the meal. If however there is GI intolerance, then we tell them to take after the meal. Now this is surprising. Dr. Shashi Khare says that the quiz questions are different. I asked different questions and in Chrome it's different, so I really apologize for that and we will ask backend team to look into this. We've answered Dr. Dollar's question. So 5 to 10 minutes before the meal, unless there is GI intolerance. And if patient is obese, diabetic, and pain in both feet, always telling pain. Now, neuropathic pain will usually be worse at night and will be worse upon resting. Uh, muscular or skeletal or arthroid, that is joint pain, will be worse on activity. So if it is always pain, it might be both of them. It might be just simple edema. So we actually need to investigate and find out the reason. DAPA, in my experience, I have not seen it causing angioedema, Dr. Sanjay. Weight loss, yes. Mostly fat mass reduction with minimal muscle mass reduction. Having said this, there are patients who will come and complain of maybe 1 out of 20 or 30 who will come and complain of a reduction in muscle mass after having started dapagliflozin. In such cases, you just weigh the cardiovascular risk and you might want to stop. If the patient is at high risk of cardiac disease, counsel the patient to continue. If the patient is at relatively low risk of cardiac disease, you can stop, you can shift to another drug. Remember to interchange. This would be a case for interchanging. Now, the best treatment for muscle mass reduction is actually not pharmacological. It is exercise, it is resistance exercise. So, encourage your patients to do more resistance exercise. At the same time, they must ensure nutritional optimization, macronutrients, protein intake, micronutrients, calcium and vitamin D. So, nutrient optimization or nutritional optimization, exercise optimization, reduce aerobics slightly, interchange that to resistance exercise. And then third would be pharmacological optimization, where you may wish to discontinue SGLT2 inhibitor for a short period of time. Fourth would be endocrine optimization, where we might wish to check the testosterone level of this patient. If it's a male patient, sarcopenia can be a not a red flag, but let's call it an orange flag. Sarcopenia can be an orange flag for hypogonadism, late onset hypogonadism. Vildagliptin, Dr. V.K. Goel says, is safe in CKD below at 50 milligram OD. 50 milligram OD. But for both hepatic and renal patients, linagliptin would be the safest. Dr. Mahesh asks another challenging question, saroglitazar. So the data is there, but long-term data is not there, sir. So I think it would be a good idea to avoid. Saroglitazar is able to bring down the triglyceride level, but there is no long-term data at all for cardiovascular outcomes. So safer drugs are there for elderly ladies with diabetes. In such people, avoid saroglitazar, and I do use pioglitazone in elderly ladies, but in postmenopausal women, you should try to avoid it. We should keep it at the bottom of our choice list. Hit early, hit hard, Dr. Armia says, yes, certainly. So, this Ethiopian proverb, Dr. Gabriel Michel, there is a snake in front of you. What will you do? You have two choices. Either you hit the snake or you allow the snake to bite you. So, either hit or get bit. Only two choices. And if you have a snake and it's a poisonous snake like diabetes is, then hit early, hit hard, hit with the best stick that you have. And just like in Kabaddi, we showed holding hands. So hit with an FDC, fixed dose combination. Do not allow the monotherapy, the dual therapy to fail and then treat, because the initial glucose control, that is the initial metabolic memory, the initial glycemic legacy, that is going to influence development of complications later on. So treat immediately, treat to target, and treat with the best drugs that you have available. And osteoarthritis, yes, is very common. Pain relief is their priority. So first we tell them to reduce weight. This would be a good indication for using oral semaglutide. You tell them to reduce weight. Then you also tell them we can't do much about the joint except for a joint replacement, but we can do a lot of things for the muscles that surround your joint. So cycling would be a good idea. Cycling, swimming, develop your muscles, and also good glucose control. So develop your muscles around the knee joint, reduce weight. And for pain relief, you can give short-term painkiller. Linezolid plus clindamycin can be used, certainly, Dr. AR. We can use together. Like we said, both have got good penetration into the soft tissue. And RA factor, Dr. Gauri Shankar, allow us to get an expert on board for you maybe next month to talk about rheumatoid arthritis. Hydrocortisone is not as effective as Visalone. Hydrocortisone is drug of choice for people with Addison's disease. It has less anti-inflammatory effect. So if it is Addison's disease, you want to give glucocorticoid replacement, which we do in endocrinology. Hydrocortisone is drug of choice. If you want anti-inflammatory effect with rheumatoid arthritis, for example, dermatomyositis, SLE, then prednisolone is better because it has more anti-inflammatory effect. Thank you to Dr. Vinay for your patience as well, and to Dr. Sanjay as well. Dr. Rajesh speaks about saroglitazar again. Again, no long-term outcomes. There are no long-term outcomes. Had it been 15 years ago, perhaps we could have encouraged its use. But now that we have drugs that have got long-term outcomes, for example, SGLT2 inhibitors we have in HFpEF, that is heart failure with preserved ejection fraction, then it would make more sense to use those. Also, male health and diabetes, Dr. Gauri Shankar, allow us to take that later. But we have done this in the past. I think about 2 months ago, we had two topics back to back for female sexual health and male sexual health both. C-peptide ideally not to be done at all, Dr. Arpan. Um, Urine ketone will tell you whether you need to give insulin on a particular day or not. The phenotype, the history will tell you whether patient has type 1 or type 2 in 99% of your patients. In 1% where you are confused, then you can get a C-peptide done. And there is actually a lot of controversy about fasting or PP. Because when you are confused, glucose levels will be high, like 400, 500. So then the point is, does it make a difference at all if you make the patient eat food or take it fasting? 300, 400 are equally high for the metabolism. So very rarely would a C-peptide be indicated. If I were to look at my practice, I think in the past 1 year, maybe once or twice, I would have advised this test. Dryness of mouth is a symptom of diabetes, Dr. Yogesh. So, the first treatment is glucose control. Stop SGLT2 inhibitor. See if calcium channel blockers are going on. Stop those. Pregabalin can cause dryness of mouth. Clonidine is notorious for causing dryness of mouth. So, look at the other drugs. Try folk remedies, for example, like ginger candies or um, ginger candies, ginger tea, cinnamon tea, and licorice. So, my favorite go to folk remedy for dryness of mouth is licorice. But, like I said, control diabetes well and look at the concomitant medication. One of the drugs would be causing this dryness. Thanks to everybody, and thanks everyone for your questions. Prednisone, methylprednisolone, both are equipotent as anti-inflammatory, so we can use either of them. And the impact on glucose control will also be the same. Whenever your patient is on prednisolone or methylprednisolone, remember that the highest glucose levels will be post-lunch or pre-dinner. Post-lunch or pre-dinner, so you have to give a drug at lunchtime. Thank you, everyone, and thank you, Dr. Goel, sir, for reminding us that it's 10 p.m. Thank you for your kind words, and the questions never end. To Dr. Nitin, I would request, we've already spoken on insomnia. So, Nitin Bhaiya, go and find out our talks on insomnia and please listen to those. Friendly and very humble request. आज का topic था choosing an OAD, and I think we have done reasonably good justice to that, Nitin. Love Humanity, metformin is weight neutral, 1 or 2 kg at the most, not more than that, in terms of weight loss. With this, I'd like to thank everyone for having been with us this Saturday evening. Thanks to people from across India and also from across the Indian Ocean. To Dr. Gabriel Michel, a warm thanks, and thanks for being part of the global family. We are working together to fight diabetes. Thanks also to Haryana Steelers, which has been my inspiration, and we wish them all the best. With this, I'd like to welcome Ankur back into the talk show. Thanks.
Thank you so much, Sanjay sir, for teaching us with your wise words, sir. And I would like to thank all the doctors to listen patiently and giving us so much time of theirs. So I would like to thank each one of you. And we will again be meeting next week with a new topic. Thank you so much. Jai Hind.
Jai Hind.